Okay.
All right. Good morning, everyone. I guess I should say it's nice to see you, but I don't have my camera on and can't see most of you, but I'm glad to be able to speak with you this morning. So I'm assuming most of you have been here before, but if not, this is the EMS Registry Users Group. So we generally talk about stuff pretty data heavy, but we also kind of touch on some other topics related to EMS data reporting and things like that. So I'm Ann Vosbrink. I'm the EMS data manager, EMS data administrator for the AZ-PIERS system, which is the pre-hospital information system. And I just wanted to welcome everyone to the meeting. I don't know if Gail or Julie are on. I want to do any bureau announcements, and then we can go into reminders after that. I know I have a couple people with reminders, and I have a couple also.
Hi, Anne. I don't think that we have anything to share. I think Gail is going to potentially share some updates. So when she hops on, we can defer to her.
Okay, that's fine. We can hop back and forth. All right, so I'll just go ahead with a couple of the things that I was going to talk about, and then we'll go back to, is Adam on the call, by the way? Because we'll talk about that one in a minute too.
Yes.
Okay, perfect. All right, Adam, I'm going to skip you for just a second, just in case Gail and you are both speaking about share, but I'll just give a couple other really quick general updates. So as you probably know, there's a federal shutdown right now, but I just wanted to let you know, in case you were curious, that if you deal with NHTSA or NEMSIS, they are not affected by the federal shutdown. So you should be able to get any assistance if you are working with any of them on anything. And then also, obviously, the Bureau of EMS is not directly impacted by that, so we're all around. And then just kind of some reminders from our last EMSRUG call. If we went over some changes that are coming or potentially coming in version 3.5.1. Right now we're on version 3.5.0 of the data set. And so we're still not looking at starting that necessarily till 2026, although actually some of the data values that have been added are already added in our system. So if you have them in yours and you want to send them over, we should be able to accept them. And I will publish those highlights that I went over on our website pretty soon, so that even if you're at the meeting, if you don't remember, which I don't memorize at all, you'll be able to access it. Another reminder, also from last meeting, but it's just a topic that it's one of those things, if you heard about it then, but you didn't know what I was talking about, now you do, it might be relevant to update you. ePatient 25, so every data element has an ID. I like to use the IDs so that we all know we're talking about the same thing, and that's patient sex. AZ-PIERS is currently able to accept that data element. It was a newer one due to an executive order that is now available. So if you would like to record that, it's each patient 25. I know there's a personnel data element too that was added, but since we don't collect that, I'm not going to talk about it, but it probably is in your system. But if you would like to collect that, you're welcome to add it. You're welcome to have your vendor add it to your export, and we can take it and it will not be rejected. You do not have to, from our perspective, collect that new data element. We are sticking with, as far as requirements, ePatient 13, which is patient gender. It's what we've had for the last, I don't know, 10 years or so. It's also what's written into rule. So it just makes sense for us to continue to collect that, so that all those agencies that aren't able to keep up on all this, or it doesn't impact, they will have zero impact from this. And those of you that want to collect both, you can, and you can send it to us, and then we will send the correct information on to MEMSTS. And I do encourage you, whether you are up on this or not, to please keep in contact with your ePCR vendor. And then if you are a billing agency, make sure you touch base with your billers, and if you bill CMS. I am not, we do not bill from AZ-PIERS, so I have zero familiarity with how that's going to work. And I don't, the last time I asked questions, no one really had a clear idea that, yeah, this is kind of new. But I wanted to just remind you to kind of keep in touch, and so that we have as few hiccups as possible for you all, and hopefully for our system as well. And then it looks like Gail has joined. And then also I have an update from Adam Rodriguez in relation to the share report. So I don't know who wants to start out of the two.
I can start quickly, Anne. Sorry about joining a couple minutes late there. So thank you everyone for joining us today. I think we've got some exciting updates about the SHARE program that Adam will get into. In regards to the Bureau, we still have a vacancy in the Bureau Chief position, but we are actively recruiting for that position. The EMS strategic plan that many of you were involved in developing has been approved by the Governor's Office. So we're really excited to continue the work with some of our ongoing strategic plan. That is a 5-year plan that started in January of 2025. And a lot of that work is really relevant to data that we collect. So thank you. I think this is a great attendance at the meeting today. And that is all I have on my end.
I'll follow up. And this is Adam. The annual share report, the aggregate annual share report is now live on the Bureau's data dashboard. And with that, we are beginning to collect a list of recipients for EMS agency level share reports. And those reports will be broken down the same way that you are seeing on the screen now, except it'll be specific to your agency. And so in preparation for getting that out to your agencies, we'd like to get a list of who would like those reports to make sure they're secure and utilized. We do ask that when you are filling out the report to use a work issued email. We can fulfill those requests. If your agency does not provide a work issued email, reach out to share at AZ-PIERS, and we can work with you, find a method to get you a report. I think that's all I have, and I will drop the link to that request in the chat here shortly. That's what I have. Thank you.
All right, thank you, Adam.
And if I can just quickly add about the share reports for agencies. So this is a huge step. We have had many agency requests for their share report. We don't have a great list for all contacts. And when we started going through that list, we saw that for some agencies, their point of contact is a billing individual, and we realized that your out-of-hospital cardiac arrest report may not be best suited being sent to a billing individual. The other piece that we also saw is that some of these are kind of a Gmail or Yahoo email address, and so we don't know if that person still works for their agency, and that's really why we do want a work-related email address to send that to. So if you're with a very small department that you don't have that, we will work with you kind of one-on-one, but just that's the reason why we really want to make sure that these are sent directly to a work-related email address. And again, why we're going to get kind of an opt-in process. So we will get this out through all of our big organizations and regional councils to make sure that every agency has an opportunity to get their report.
Okay, thank you. And I'll follow up with 2 other things with that. So I think Adam put in the chat a link to a Google form. So you guys are probably pretty familiar with Google Forms. I use them for a lot of things, so I can track stuff. And when you click on that, it will allow you to add, I believe, even more than one person for your organization at one go. But you're welcome to just tell the people at your organization, go click on this and add yourself if they want a copy of that individual share report. It'll be a bit of a learning curve, and we'll probably just need to maintain this list, but it's a good process so that we can kind of track things. Also, I believe, as Gail mentioned, it's going to go out to the regional councils, this announcement, and I believe there's also going to be a Gov delivery going out that will include this information and the link to that form. So if you are not already signed up for Gov deliveries, this is a good reason to sign up for Gov delivery. I don't have the link right on me right now, but if you guys have ever gotten an email from me, which you probably have, I have it at the bottom of my email signature. There's a link to sign up for Gov deliveries, because we do send a lot of very timely and generally more, I won't say urgent, but high level things that we want organizations to know about through that Gov delivery. So please consider signing up for that if you are not already. If you have any questions at all, you can reach out to Adam. Adam, can you put your email? I'm sure everyone probably has it, but could you put your email in the chat too if you're still? Okay,
absolutely.
We're super excited about this. There's been a ton of work done on these reports, and you guys are really excited. And Shelley had just displayed where the annual share report is. I would suggest taking a look at that, seeing if it makes sense to you, because once you get your individual report, it's going to look very similar. And then if you have questions, you can you know, try to get them in advance before you're trying to pick through that report. And we would really like your questions, or if something is confusing or something doesn't, because this is our kind of our first go at it, and we're anticipating that, you know, there might be an additional material or something else that you guys would like, but we're not going to know that unless you tell us, because of course when you make the report it always makes sense. So, anyway.
Hey, Ann, I'll just show them how to navigate to the.
Yeah, that'd be great. Thank you.
I know.
So
On our webpage, we have a left-hand side ribbon menu, and this is the sign up for email updates. This is get you signed up for the Gov deliveries.
And can you just show them where to navigate to that annual report, to the share one? I know yeah, good.
Yeah. For the share report, you will go to data and quality assurance, and then stay on that left-hand ribbon, data visualization, and then your options are on this top bar.
But the share report's something else. So yeah. Well,
It takes a minute to load.
and for those of you who read the statutory meetings, I don't remember if it was last week or week before last, because time flies, but whenever that was, this was presented also. So you may already be familiar with it. Okay. Does anybody have any questions on that before I go on to a few other announcements, and then we'll see if the group is ready to present?
Looks like Dr. Rice has raised her hand. Go ahead.
When I pull up the form, just a quick question. It doesn't look like there's a place to put in your EMS agency or agencies. It just has you put an email in. So for those of us that are working from other emails, we need to email the DHS individually. Is that correct? Just so I can pass along the right information to our group.
Hi, Dr. Rice, this is Adam. Yes, you can email share at AZ-DHS for that, sorry.
Okay, right.
Amber, are you saying there's not, the form should have an agency name? Yeah, Adam, do you know, I know this is our first roll. Like you had like very little time to get this together.
No, let me see if I can add that in really quick.
Yeah, if it's not there. So yeah, thank you, because it is helpful to have the agency name, even if it's obvious from the email address. It makes
Well, for like the medical directors, we might have multiple agencies, and we have the same email address. So
yeah, good point.
Yes, thank you for that. I'll add that in.
okay, thanks.
Yeah, and the one piece that we do recognize is that once an agency has the report, they are more than welcome to email that out to other people within their organization or their medical director. We just don't want to send these to non-work related emails. So for anyone that is using a Gmail, that type of email address, we would not send those to those. If someone has a work email that is connected, otherwise that we are happy to send to. But otherwise the agency can, once they receive the report, forward it to whoever they would like.
So it will only go to that agency specific email?
Yes, that is the plan right now.
Okay.
But I think if there's a medical director that has an email that's for their hospital and for several agencies they would like to report, I'm sure you can work with.
Yeah, I mean, if it was a hospital one, I think we just want to make sure that it is the person getting that is authorized to get that, because people change positions and move along. And so if someone is at a hospital and goes to a different hospital system but are no longer associated with that agency, we want to make sure that if they're getting the report, they should actually get that data.
Thanks.
And once again,
That agency name's been added. Thank you.
and if you do only have a Gmail account because you're with an agency that doesn't have its own domain email address, then contact the share program, because we can absolutely work with that. It's just for the default on the form, we'd like to you use your work email if you have an official one as opposed to a personal one. Okay, let's see. There will be a new schematron coming out very soon. I just sent off the updates to ImageTrend to have them build it. I'd estimate that it'll be available sometime mid to late week after next, so the week of October 20th. I had quite a few changes, which is one reason it's taken so long. So we have several new facilities, including one new hospital that will be part of it. That's pretty typical, but we also have a lot of validation rule changes, which is not typical. Usually we have maybe 1, 2, 3 We have 24 validation rule changes in this one, and 3 validation rules have been inactivated because they've either been combined with something else or they kind of were checking the same thing. So I've had a lot of agencies over the last few months ask questions, and I finally started pulling all of it together. So there will be change logs. If we have time at the end of the meeting, which I kind of doubt, I'll show you guys some of the change logs because I'd love to get your feedback and if those are helpful. But just expect that to be available fairly soon. And then I'm out next week, so I will have an out of office reminder, but just in case you're trying to get a hold of me, I'm out next week and I'm not planning on taking my computer with me because I'm going to the beach and sand and computers do not mesh well. So let's move on to our item 3. And we have Dr. Rice on, and I'm not sure who else from the group is on, and they have a topic they'd like to discuss related to blood glucose level testing and validation rules.
Sure. I think it's just me for our group.
And do you have that thing displayed that was emailed with the original email? Do you want that up on the?
We can, yeah, for everyone else to kind of look at. And I'll give a little bit of background. So we've had some discussions within our agencies locally about which patients need fingerstick blood glucoses for, which protocols and which patients we expect them on, and that we don't expect them on every patient, and have written our sort of internal protocol to send around to folks, and then realized that it might conflict with some of the current validation rules. And we don't want our agencies to get dinged on their validation scores for missing an item that we told them they didn't have to get. So I think we just want to kind of circle back with this group and talk a little bit about specifically the validation rules on the fingerstick blood glucose requirement. So it seemingly, I think that the list I had pulled up from Northwest Fire had some additional things on it, which they said is their most up-to-date version, but then it didn't look like what Anne had sent me. So I'll let Anne pull up what she had. But there's a list of primary impressions that require a fingerstick blood glucose. I don't know if you need that one, Anne, necessarily. I just meant the validation rules as they currently stand. Your current. So I think in our mind, we were looking at limiting the fingerstick blood glucose requirement to items in which there was either like an altered mental status or something related to diabetes. I think there were some pregnancy related ones on there.
Yes, sorry, I forgot I was on mute. I'm going to put it on the screen just so you didn't think I was ignoring you. I just had to pull it up. And sorry, this is the actual, so let me make this bigger so you can see it. Usually I take little snips of these, but
yeah,
it is so small. All right. I can pull up. Let me know if you guys can see that okay, because I can make it bigger even, but.
It's not, no, it's fine, Anne. I think it's as good as it's going to get probably on there. So I think our question were, potentially some of the items like TBI or the schizoaffective disorder, some of these things that I wouldn't necessarily think would require a fingerstick blood glucose, and maybe discussing with the group if there are items on here that we may be able to move or remove off of here, like quadriplegia was an example, respiratory failure was an example. So there were a couple of things that we didn't want to tell our agencies, if they're not altered, don't worry about it, and then have them get dinged because it was a respiratory failure patient, they didn't get a blood glucose on them.
I would say many of these probably can be removed. I do think TBI, that's kind of one of the big things with the EPIC, was checking a blood glucose if they're altered. So I don't know that I would remove TBI.
Okay.
But I do think, when we look at like opioid abuse versus opioid abuse intoxication, like if there's intoxication and altered mental status. So I think like we could probably go one by one. Like I think the ones I would kind of propose taking off as well would be opioid abuse.
Agreed.
Psychoactive substance abuse, schizoaffective, bipolar, stimulant abuse, and then like I'm not sure about dehydration or diarrhea, if
Yeah.
those are needed.
Yeah, those are the other
Um,
two on my list.
The drug overdose intentional is probably a reasonable one in case they've taken anything that also can lower blood glucose. I would keep that one. The nausea and vomiting, that one potentially keep in case this is a presentation of diabetes. And then I agree, respiratory failure, there wouldn't be a gain. And I think the new national sepsis recommendations no longer include a blood glucose either.
What about quadriplegia?
Oh, yes. Yeah, quadriplegia, I agree.
Yeah,
And
sort
I
of
think
similar to them. And I think the pediatric birth injury, preterm delivery, those are probably okay.
Mhm.
And then we thought anything with like a behavioral change, anything with a mental status change or weakness or any of those we felt were appropriate to keep. But then the ones that were just, I think the ones you listed were all the ones I had on my list to potentially remove.
I do think, and even preterm delivery, I mean, it's one of those pieces, if the baby is vigorous and looks really good, do we necessarily want the crew worrying about getting a blood glucose?
Right.
If the child's crying and you get a low glucose, do you have to like struggle to get an IV then if the child is otherwise well appearing? So I think that is one the group could kind of discuss. Do you think it's necessary or not?
And I think something else that y'all can consider too is, you know, it's not always infinite amount of possibilities, but you know, this could also be altered. You can take some off, you can leave some, and then we could add something in saying, or if secondary impression includes ALOC, that kind of thing, just as an example. So there might be some other tweaks we can do to kind of tie some of these to something else. But
what about alcohol ETOH? That's the other one I had on my list. Like if they're just intoxicated.
I think there's two areas. There's alcohol abuse with intoxication, and then there's just alcohol by itself. So I would say maybe keep intoxication because you want to make sure it's not a low glucose that you think is causing that, but maybe just remove the just ETOH in parentheses alcohol one.
Okay, good. Agreed. That was the other one on my list. And then some of these, I just don't know that they're used super often anyways, like pediatric birth injury. I don't know that I've ever seen an EMS crew put that, but.
Yeah, I think when this was set up, it was done off of some national recommendations and standards because we were trying to limit it in the first place because it used to just have to be blood glucose for everyone. And then I know, Amber, the discussion when you guys had it down south is partly based around an older validation rule that already had some stuff removed. This is the current one though that we can alter. I'm fine with whatever y'all want done with this. Or like I said, if you want a further discussion about adding in some, or if it's this and this together, then yes, that kind of thing. What would you like back from this group in this meeting right now? Do we want to see if anybody in the group has any counter examples or agreement, disagreement, or maybe their agency works slightly differently, things to consider? Does anybody on the call have a 2 cents to put in? Or you can think about it too. You don't have, we won't immediately.
Hey, this is Chris from Eureka Fire. You guys hear me okay?
Yeah, we can hear you.
Okay. So we've been kind of tiptoeing around that same topic of who deserves getting their blood sugar checked and who doesn't. And it got really into the weeds, we thought. And we kind of went down making it just a standard assessment tool. But of course, there are those certain situations where maybe it's not done and the provider is really able to document why it wasn't obtained or let us know. And it seems to be working well. So that's just kind of my 2 cents on it, because like I said, we got into the weeds of who gets it, who doesn't get it, or what about this? And what about this and all the what ifs. And we've kind of just standardized it as an assessment tool.
So did you, Chris, just for your organization, did you end up limiting it? I mean, when we're talking about this rule, it's more just when you send something in, this validator is going to take off a point if you don't have it, you have these impressions.
Right.
But, and that doesn't mean you can't put it in there if you don't have these impressions. It would never say, don't give us a blood glucose. But I just wanted to know what your organization decided to do. Did you just leave it for anybody, or was it more just if it was in there, you figured your provider knew that it should be?
Yeah, pretty much.
Okay, yeah, because certainly I don't think that validation rules should ever drive clinical. That's not the point of them at all. They're supposed to try to capture when we're not getting stuff, and we really should be, which is always an impossible thing to be perfect at. So I don't ever mind changing validation rules because I don't feel like it's my personally being, overridden. I do think that we all owe
And sorry, there's hands up.
Oh, sure.
Go ahead. Yeah, Brian, I see Brian Joseph.
Oh, that's okay. Thanks, Doc. Hey, Ann. I guess two questions. One, maybe because I missed part of it, is what was originally driving the decision to make the alteration, and were there gaps in the data that you were getting? And then secondly, I'm on kind of the same board with Christian, is, letting it be provider decision, because a lot of the time, really, those patients that maybe we should have got it, based upon this list that I'm seeing on the screen, that we weren't able to get it. Now we're going to have validation schema rule errors because we weren't able to get it because of a particular reason. So in the vein of kind of letting the clinical drive the validation as opposed to vice versa, maybe there's a better data set value that we can base that justification on, as opposed to maybe the e-situation 11. And I'm trying to dig through my form here while I'm digging through that, but I'll just put it out to the group for thought and discussion.
I want to answer the second part of your question just real quick, because that's the part, and then we'll go back to the first part. Just on this rule, as far as blood glucose, if you just couldn't get it, like even if it's on this list, you couldn't, there is the second to the last line. It allows those pertinent negatives, which is unable to complete or refused, and that will satisfy the rule. So if you get one of these impressions, whatever y'all decide that we want to have in here, and then you still can't get the glucose because someone's, violent, you can fill it in that, and it will allow that.
And so I think there may be a little bit of confusion. So this is already existing. So currently, if you had something on here and your crew did not obtain it, so just say respiratory failure, the crew put the patient on CPAP, did SVNs, etc., you did not get a blood glucose, because it's currently a required element, you would lose 1 point on your validation score. So just to make sure everyone understands, kind of currently, these are all the required diagnoses to get a blood glucose check. And if the crew does not obtain one, you lose 1 point. So the request, I think, from Southern Arizona, as they're trying to kind of help their with their agencies, is they didn't want to say you don't need to obtain blood glucose if the agencies were then going to get a lower validation score. So I don't know if that makes a little bit more sense. Certainly as an agency, you could have this as standard or just leave this be a clinical, but right now from a state validation perspective, these all are required diagnoses or impressions to get a blood glucose.
I got you. Thanks for the clarification. Yeah, I do remember seeing, some of the validation errors on ours. So let me retract my prior statement, mute myself, and think about it a little bit more before I come back.
Yeah, I think what we have been doing down here in Southern Arizona is essentially, or at least with some of our agencies, end up turning off the flag for certain things and just eating the points lost on the validation score, but making it less challenging for crews to complete their reports on some of their calls. And so we didn't want them necessarily to be having to turn off flags for things so that we can close out reports, but in the back end losing points on the validation score. So for some of our agencies, it's not as big a deal. For some of them, the points matter a little bit more. So I think we're just trying to make sure that what we're asking of them is consistent with what the validation requirements are. So I guess that's kind of where we started with this whole conversation.
I see Greg, your hand is up.
Okay.
Yeah, thank you, Dr. Bradley. I guess I'm just in the, this is more of a clinical decision at the state level that I guess produced this, and maybe it went through medical directors or something like that, where you were seeing this or whatever reports you were doing. But I think to Dr. Rice's point, I like to see it more of led by medical direction in our region, and I don't want to be dinged, or I know at least the fire chief doesn't want to be dinged on any schema scores. And so that's why I think I'm in support of this, is allowing more of the medical direction on a local level. And then if something comes up, then maybe the state medical directors brings it up in that meeting, and then maybe there has to be some revisions. But I don't see why we can't change these rules to be more driven by whatever's happening locally, you know, whether it's the Phoenix market, Tucson market, or Flagstaff market regions. So that's just my 2 cents.
Do we have any other hands raised? I can't tell if there's anyone else that had.
I don't see any hand.
Okay. And Amber or Gail, feel free to step in. So it sounds like for those that have opinions so far on this, that have thought about it, that there are definitely things that should be taken out of this list, whether the list should just go away completely, or at least we can get it down to ones where it would be very reasonable to think that you could either, we should have a blood glucose, or you fill it in as you refuse, unable to complete. It sounds like either way, the group is in favor of narrowing this down a little more and maybe adding some things in to make it a more narrow scope. If anybody doesn't agree with what I just said, let me know, and then I can work with, I'm not sure exactly what step I would do next, but I think I would probably work with Dr. Bradley and Dr. Rice to get a good idea, and maybe we can send out an update or an email. But this will probably be a new process, and I think it's a good one, because this is probably one of the, there's only a few, but there are a few validation rules that kind of look at limiting it by things like impression. And Brian Joseph from Scottsdale, if you come up with some other ideas of other data elements that might be able to kind of work in with this, I think this would be a good thing for our group to look at. It also might be something that if there's some kind of volunteer committee out there that is out of PMD or whatever, that can be used to discuss this, because it makes sense. We don't want to drive clinical things with validation rules, but we also want to make sure that we don't say someone's got a great score and then it turns out they're not giving us things that, or the hospitals things that are really critical. I want to balance that. But these aren't my rules. These definitely should be going by what the clinical needs are. So any other comments at all? And then Dr. Rice, do you have anything to, I don't know, summarize with what you'd like to do?
No, I mean, I think that I think Gail had a very reasonable selection of items that she felt comfortable with kind of working with you to remove. So, I mean, I think we kind of had the same ideas. So I'm fine with however you guys want to work it, and happy to review the list again. But yeah, I think what the list we kind of had reviewed today is good to me.
Okay, perfect. And maybe this, like I said, will be a new thing. We can, I can try to find some time to pull up some other rules, I'm sorry, that have these kind of caveats in them. And maybe we can find a group of people that are interested in reviewing them, that are medical directors. And if we don't get to them, we don't, but that way it can only improve the process, because standards do change. And even if these rules maybe had things in here that made sense on some standard back in 2022, when a lot of them were originally written, things may have also changed. And okay, thank you so much. I think this was a super helpful topic for everyone, and honestly a really valuable one. And I look forward to having you guys back on another topic sometime. Okay. Let's see. So the next thing I'm going to talk about are really just some data quality focus items. And thank you, Shelley, for pulling back up the agenda. I did make some slides just because I think it's easier to present something when you're actually able to look at something, but it's nothing that's really complicated to look at. So I can pull up, I don't know, Shelley, if you have I can pull it up if you want to. Okay, thanks. These are not super fancy. I did them last night after I did some more calculations. So can you move on to the first slide? We're going to skip around a little bit, but okay, thank you. Maximize my screen so I actually can see it too. It's the same. All right, so one of the things I wanted to talk about is initial patient acuity and final patient acuity. Final patient acuity, by the way, has had a name change. It's now, I think, acuity at patient discharge. I'll have to look it up. It made it longer. Basically, the idea being is it's not, EMS was concerned because they don't really know the final patient acuity when we call it final patient acuity, and all times, sometimes it's the acuity when the last time they saw the patient might not be the final acuity. They don't know what the final acuity was. So that was, I think, why they did the name change nationally, but I still have been calling it final acuity because it's shorter and easier to remember. For those of you that are interested in what data elements these are, they are E-situation 13 and E-disposition 19, which I'm sad to say I have memorized now. But these have become, they've always been important, but they've become a lot more important since we started working with the data for share. So I took some initial kind of looks at some of the information that we had in our system just for the year of 2025. And for situations where there was patient contact made, so if you don't have a patient, you're not going to have an acuity, so it shouldn't go into the when we don't have an acuity calculation. Acuity was completed in about 84% of the records where we would think that it should be completed. And then in about 16% of the records, which is not bad, but could be a lot better, a not value like not applicable, not reporting, not recorded, or blank, or some other, there's a few other really random values that were submitted. So make sure you check your systems that you're not submitting something that isn't a normal NEMSIS value. And I can pull up the data dictionary if you want later to kind of see what they are off the top of your head. But I would like you guys to just see if you can go back to your ePCRs and make sure that this is something that is getting recorded by your crews or however you're capturing it when you have a patient, and that you're filling it out. These are the ones where it's like critical or, you know, low acuity or non-acute, or in the case for the cardiac arrest, one thing that caused us to highlight this, and it's the same thing with final acuity, is one of the only ways to determine if it's a cardiac arrest but not a viable cardiac arrest for various reasons. And there are other data elements you can answer, you know, this was a DNR, or this was, you know, considered not viable or whatever, but there is a dead without resuscitation attempted is one of the values for initial acuity. And that is one of the key ways, and honestly, one of the only clear ways to be able to, when you have your share report, which you want is you want to really see what was worked on the viable saves. And if we can eliminate those that were DOA without resuscitation attempted, then those are not going to get mixed into your percent. So when you look at, you know, how the cardiac arrest, out of hospital cardiac arrest is going in the field. So that was one reason. Final acuity is kind of the same thing. That one I limited to, there was patient contact and if the patient was evaluated and care provided. And then I also removed if the initial acuity was equal to dead without resuscitation attempted. I did take those out. You can answer final acuity, but my thinking is if they're dead without resuscitation efforts in initial acuity, then you're probably not going to have a change by final acuity. So it's okay if those weren't filled in. If your initial acuity said that they were DOA, then they're still DOA as long as you didn't fill in the with resuscitation efforts, because that's an option too. So in final acuity, we had still a much lower completion rate than we should, because these are patients that you had a patient, you cared for them, you evaluated, you cared for them, so they weren't like a refusal or whatever. And also you did not say that they were DOA in initial acuity. And we only have a completion rate of about 64%. So this definitely is coming up as an issue with share reports, and it'll come up with an issue in general when we look at deaths. So the It also is going to affect a lot of the validation rules I changed, because some of the changes I made is if the patient was DOA in initial acuity, then you don't have to do a lot of the vitals. So that's another good reason to fill this out. But yeah, so if you could please focus on the initial acuity and the final acuity if you do provide care for that patient, and if they're not DOA in initial acuity, please fill those in, because we have about 27% of the time that they're either put as a not value or as blank. And as far as I know, all of these really should have an acuity. And then there was 9% where, and I'll work with those agencies, but there are some older values that are present in some of the ePCR systems. They were actually ones that, I guess they could be custom values, but they went away in 3.4, and that's the ones where it's improved, unchanged, or worse, I think are the choices. And that doesn't help us at all when we're trying to figure out if somebody is has died, because obviously if they're worse, we still don't know, what does that mean. So please make sure also that in your systems for your final acuity, which is e-disposition 19, that you do not have those activated. If you have an issue with this or there's some problem I'm not aware of, please contact me so I can understand better. But I would really like everyone to focus on those if possible, because that's really going to affect your share data for 2025 as well. Okay, does anyone have any questions on that before I move on to the next kind of data quality highlight focus items? Okay, Shelley, can you go next slide? Thanks. All right, this is a general reminder, but I highlighted some of the ones that I thought were the most, some of the ones we found useful or that we've used. And I know delays can be a pain in the butt to document in every single one. They all should have a none reported available as a value, because if you don't have any delays, then you don't have any delays. I don't know how often agencies are really able to use dispatch delay, because that might just be something that your dispatch center would fill out. But some of those are, if there's no EMS units available, or there's no receiving bed or hospital available to take the patient, that's something that you would want to record if that is a dispatch delay, because especially that second one, that's not something in your control. Response. So if there are events like crowds, road obstructions, traffic, there was a study done on survivability, I think of cardiac arrest, related to people who were housed near the Boston Marathon during those events, and they found a significant decrease in, I think, survivability. So that stuff really does matter to if you can record if your response was affected by, crowds or, whatever you're trying to get through, weather. And obviously if you're responding out of service area, you can put that as a delay also. For scene, I think this one is particularly important based on feedback that we get from agencies. So your scene delay could be extrication. Also, if you're delayed on scene longer than normal because you are awaiting an air unit to show up, or you're awaiting a ground unit, whether it be yours or a contracted agency, if there's safety issues with the crew and staging, such at an event where there's shootings, safety of the patient, and even distance. So if you're going to be on the scene longer because you have to hike up to the patient on the side of a mountain, that could be one of them. Transport delays, some of the ones, like I said, there's longer lists that you have for those, but things like, once again, if you're trying to get through a crowd, your transport might be longer, and that is something that you cannot, you can't control if they've shut down most of the roads in an area because of an event. Also, once again, if you're rendezvousing with a transport, so say you're an ambulance and you're going to where you're rendezvousing with an air agency to transport your patient, that can be a transport delay because you can't transfer care until you have somebody you can transfer them to. Also, if you're diverted to a different location because maybe that hospital is no longer taking patients, or a route obstruction like a train, or anything else like that. And then lastly, turnaround delay. We don't see as many of these, but if you have to do equipment or supply replenishment, like you need to get some, drugs for your drug box, or there also was like decontamination and cleaning, which I'm sure happens if you get some particularly difficult transports. And then ED overcrowding or transfer of care. This is something we hear from agencies a fair amount is that they had to wait quite a while on transferring care of the patient when they already are at the destination. So make sure that if that is affecting your turnaround time, please record it. I know these are kind of like little things to remember to do, but when we get information back that things are an issue, this is one of the main places we're going to be able to find a trend or not. And it's one of the only places that we can track it. So just a reminder to get your crews, if you're experiencing any of these on a regular basis and you feel like that they are pain points for you, make sure your crews are noting them, because that's the only way we really can tell that that is the case. Does anybody have any questions on that before I move on to the next? Yeah. Okay. Shelley can move on to the next one. Okay. So this is this next two are questions for the group. So if I don't hear anything back, I'm not exactly sure what I'm going to do with that information, but I'm happy if you don't want to speak up on the call and you just want to email me or whatever. I would love to hear back later as well. So for various things, one thing I was looking at lately was dispatch priority. So just, this is not a required data element right now. It's optional. So the fact that it's not filled in very well is not surprising to me. But I wanted to find out from you all, as far as dispatch acuity. So it's the same kind of thing. If someone's red or green or non-acute or yellow, or that this is something that dispatch would perhaps get from the caller. And I think it would be something that would be auto-populated by your CAD if you get it from your dispatch centers, but I don't know how realistic that is. So I kind of wanted to find out, when you're dispatched, do you guys usually get this information? Even if it's not recorded in your ePCR, is it something that you generally could get and your dispatch center could provide to you? Go ahead. Somebody had a hand out.
This is Gail. So I think the question I would have for Anne for clarification is this asking, is the unit being dispatched lights and sirens or not? So code 2 or code 3, is that what this question is referring to?
Kind of, because we don't have code 2 or code 3. There's not that kind of data element, and that's something that nationally isn't defined the same. And lights and sirens and not lights and sirens isn't, you can track it, but you have no idea during which point in time you were or weren't. So this is kind of looking at, the idea is how easy is it for you to be able to get the information that what the dispatch center has determined that the patient acuity is. So a little bit of that, just trying to look at this from an angle. Yeah.
So I think that was kind of my question, and then turning it over to the group is, we do at the Bureau get quite a few questions on what is the volume of kind of lights and sirens or code 3 versus code 2 transport. We have no way of gathering that. So I think that would be kind of the answer to the group is, people might not be filling this out, as we're seeing almost 75% of the time, because they don't know what the question is asking. So I think that is maybe where the gap is, but is this useful or not? And then I see Will has his hand up.
Hi. So Maricopa Ambulance, our dispatch center, our dispatchers input that information before kicking it out to our crews. So it's already on that chart.
Okay, and that's helpful because sometimes even if you're getting it in yours, not everything is sent over in the XML to us. So for example, in that situation, I'm not promising anyone we're going to add anything. I just want to promise. It's more just looking at if you're getting it, then it wouldn't be a lot of extra effort if we're not getting it to just have it added to your export. Whereas if somebody doesn't get it at all, how frequent is that? So thank you, Will. It's good to know.
Christopher's next.
Yeah, this is Christopher. I work for AMR. I know our dispatch can put in the acuity. The problem that I've noticed out in the field is the accuracy of it. So you might get chest pain, but it could be chest pain that's been going on for 3 days and it's just a strained muscle, or it's chest pain during an active MI, and the acuity of that patient is different. But we don't know that until we get on scene.
And that's actually a really good point, because part of this is trying to look at what is the acuity told to you by dispatch before you get there. Because once you get there, you can realize that it's worse, or maybe not, like you said, not the issue that it was originally determined, but that initial acuity that was communicated with the crew before you were actually able to get to the scene to determine the real acuity. It sounds like that's something you guys or that your agency receives from your dispatch. You're just saying it's not always accurate when you get on the scene, which is an important distinction, because although that's not why I'm currently looking at this data element, I think that is something that I've heard with dispatch reason as well, or at least in the past, agencies have told me that they don't fill the dispatch reason, and I haven't looked at this in a couple of years, but at least at the time, that the dispatch reason always reflects very accurately what they find when they get on scene, which is important because sometimes we do try to use the data that way. And but it sounds like at least 2 agencies say they do get this at least from their dispatch. Anybody else have?
Greg is next, and we have about 10 minutes left on this time slot. Go ahead, Greg.
And I think this is something that I talked with Rachel and Dr. Bradley when we did our stakeholders meeting, but just remember the rural areas are dispatched by usually sheriff's offices, and they don't get very much of any information, if at all. It's like, you know, go for, you know, somebody pinned somewhere and take a left at the second red house, right? I mean, the information, so whatever information you're looking for might be inputted by that provider and might be very inaccurate, or depending on what provider puts it in. But the dispatch centers themselves, there's no CAD link. It's very limited on the information. So I would just be cautious. Just remember that not everybody's in the Phoenix or Tucson areas and or works for Maricopa or AMR, right? So a lot of these smaller mom and pop places or mom and pop EMS agencies, they just, you know, it either comes over on a 7-digit line. In fact, I think there's a place in Cochise County, they call the hospital, which calls the ambulance service to have them respond. So.
Okay, so, and that makes sense. I think that's a lot of dispatch information is difficult to capture or captured quite differently if you don't have a CAD integration. And it sounds like that's the same with this. Okay, let me move on to the next one. We just got a couple more things and then we'll end the meeting. Can you move on to the next? All right. Oh, actually, never mind. Go back, please. I have one that I don't have a slide for. So this is something else, and you know, this might take more discussion later.
And there's a hand up. It's a couple hands up. Sorry.
Please go ahead.
Go ahead, Heather. Hi, yeah, I was just going to comment on the 2, obviously, regional dispatch centers in the Valley have different CAD feeds that are going to fall in. So it's really just being able to understand what the CAD is able to give us into our systems, and then really what you're looking for based on this data element. It's obviously what the dispatch centers field at the time. That's one data element. Whether it's code 2, code 3, that's a separate issue. So it's really what the regional dispatch centers can then bring into our system already, and then it's potentially custom mapping into the vendor ePCR.
Okay. Yeah, it sounds like we probably need a little more discussion about this then when we have some more time at a later time, but you might be able to get some of it, but to make sure that it actually, like we always mentioning, you know, trying to figure out if the dispatch level, because there is not a, if you're doing code 3 or code 3, it's something custom to the state. And so we need another way to track that. Okay. Do we want to, we can have some more comments on this, or we could move on to the next one. I don't know, in the interest of time. Does anybody have anything that?
SFMD added to the chat. We use e-response 23 to document code 2 versus code 3. We then validate it. And I can add this topic to the next draft agenda.
Yeah, let's add it, but I'll look at it. I think that's the one where it's multi-select, so there's no rhyme or reason for how long each one was done. So there's no real way to determine if you started out one way and went the other way. But let me look at that. I don't have that one memorized. Okay, let's just move on really quick to the next 2 items I want to get to before the end of the call. We may run a little over, but so I did get a comment from an agency, I don't know, like a month ago, and I wanted to explore it with this group a little bit. So we have a transfer of patient care date time. So that's not the one when you're at the destination. That's a separate one. This is when you might transfer care to a transporter, or, you know, an air agency, or, you know, whatever. And I had been looking at this as, you transfer care, so now they're taking over care and you're no longer caring for the patient. But in 3.5, you can indicate in one of the disposition variables that you were primary care and then you transferred care to another agency. The thing is, it doesn't say whether or not you transferred care, like you waved goodbye to the patient, or if you transferred care and then you actually continued to help care for the patient, but in a supporting role. And so I wanted to know if that's a pretty common use of this. Do you, as an agency, when you transfer, do you put down a transfer of care time, and do you frequently transfer from being the primary caregiver to a support one, and then you hop on the ambulance and provide care? Because I want to make sure that I kind of understand how you guys are using these. I don't know if anybody is, if you're confused with what I'm talking about, I might just save this for the next EMSRUG then and kind of do a little graphic.
I think that might need a little bit more like visual description to make sure we're getting good feedback on that one.
Okay, I'll work on that for next time. And then, can you go on to the next slide, Shelley? The last slide that I have? Okay. Thank you. All right, so this was prompted partly by a discussion that was had in one of the statutory meetings about being able to individually track injuries from e-bikes versus e-scooters, and separately. We did have a way to kind of do that in our system, but it wasn't really that specific. And then Tanner from Mesa sent in a question that was really interesting to me, asking about that. So I dug in a little deeper, which led down a whole rabbit hole, and looked at our national recommended list. And it turns out that there are some updated codes that have come out more recently for ICD-10. And I know on the front end, your guys don't see the ICD-10, and that's fine. They're just going to see whatever you label it, that now allow us to divide these out. And so my suggestion would be, we're going to have some discussions nationally about adding these to the defined list. The Trauma Registry Users Group met yesterday, and they have updated their codes to follow these codes that I have displayed here. There are some more generic ones, but I would recommend that for your e-injury 01, which is cause of injury, they're called e-codes, that you add these if you don't already have them. And then you don't have to use these labels. The official descriptor is there, but sometimes it's easier to relabel it so you can give examples or searchable words. Like my e-scooter, I put e-scooter and e-bike so that if someone just puts an e-scooter, they'll be able to find it quickly on their search list. But we would recommend that you use these codes and then label them appropriately. So accident on a Segway or hoverboard was the first one. Used for e-scooter injuries, that's the second one. And then the third one is used for e-bike injuries. There's been a huge amount of interest in this, and also, just like I think with a lot of things, like when we found with like the wheelies, when the kids had those shoes, they had wheels. There's a lot more injuries from them than I think people originally anticipated, and that's something that we definitely want to be able to track and look into, and maybe address for injury prevention. It's something your agency also, if you can track it, you might be able to look into adding that to your injury prevention for your community. So I don't know if there'd be any questions on that or not. If there are, we can have some questions, and then I think I'll finish up so that we can end on time. We can do a little, I'll stay on at the end for a little Q&A if anybody has any. One of the items we're not going to get to this time is feedback on the data quality and monthly snapshot reports. So I just want to mention that I think everyone on this call, maybe not, if you're a hospital, then no, but if you're an agency, you or somebody at your agency should be getting weekly data quality reports, but then also a monthly data quality report that sums everything up, and a monthly snapshot report that has all kinds of information, like what meds you gave for the month, the destinations you went to for the month, that kind of thing. So first of all, if you're not getting this and you feel like you should be, please let me know, because it's a scheduled report. It goes out, the monthly ones both go out on the 5th of the month. And then I also, and we can discuss this more next time, if you have a chance to look at the one you got this month, or even the one that comes in next month, take a look, see what you think. And I'd love some feedback, because we can tweak these, we can add things, we can maybe change a definition in how something is run, so that these are actually something that's useful, so that you want to look at. And if you are a premier EMS agency and you are getting a share data quality report monthly from our system, that's completely different from the individual share clinical report that we were talking about earlier. Those go out on the 12th of each month. So once again, take a look at those if you've been getting them. If you haven't been getting them and you're a premier EMS agency and you would like to get it, and there might be someone else at your agency getting it, but I'm happy to add people if they're an additional appropriate person for the data quality for the share data. And I think that is it for the meeting content that we can get to. I will stay on for open forum, or if you guys have requests or questions for the next little bit until people decide they don't have any questions. But otherwise, thank you very, very much for coming. And hopefully we'll have another one. We should have another meeting before the end of the year. And hopefully by then we'll have the individual share reports, and maybe we'll be able to cover a little bit of that. So that'll be awesome. It looks like some people have put some items in the chat as well. So feel free to check those out if they are relevant to you. And I really appreciate everyone's time and being on this call. So thank you.